So that's a great question. Over 50% of our patients have comorbidities like chronic kidney disease, heart disease, peripheral neuropathy, or hearing loss, or just poor performance status in general, which makes them unfit to receive cisplatin, which can have renal toxicity, ototoxicity, and neuropathy as the key side effects. And obviously, patients with significant heart failure cannot get cisplatin because of the fluid overload issues. So these comorbidities make it challenging to treat these patients. So we need agents that will not affect these criteria or these comorbidities. And the challenge is to find treatments that are well tolerated by patients who have all these comorbidities. Yeah, so that's a great question. For frontline therapy, for example, for patients who are cisplatin ineligible has really evolved over the last few years. In the past, gem carbo used to be the only thing we had for these patients. Median survival were really dismal, 6 to 7 months, up to 9 months maximum. And then when we had single agent immunotherapy like pembrolizumab and atezolizumab approved based on single arm trials, that became the preferred option back in 2017. And then in 2018, there was label restriction for use of single agent immunotherapy because the preliminary data from phase 3 trials comparing immunotherapy versus carboplatin-based chemo in cisplatin ineligible patients showed that patients receiving immunotherapy were doing worse. So finally, in 2020, we had the Javelin Bladder 100 study come out, which showed that patients who received gem carbo for patients who were cisplatin ineligible, followed by avelumab maintenance, had really improved overall survival. So, and more recently, based on the negative phase 3 trials, Keynote 361 and IMvigor 130, our preferred option for these patients is carboplatin containing chemotherapy, followed by avelumab maintenance. The FDA further restricted the label for pembrolizumab to only those patients who are ineligible to receive even carboplatin. Now, having said that, if patients are given immunotherapy in the frontline setting, then enfortumab vedotin has shown activity in the EV-201 trial in one of the cohorts. But I will say that the general standard of care currently is to use carboplatin-based regimen when possible. And if patients are getting single-agent immunotherapy only, which is not a majority of patients, that drug is an option.